The less you see in my face, usually the better anyway. All right. Welcome, everyone. We might get started now that it's ticked over 12:30. I'm Rob Campbell. I'm one of the co-clinical directors of the Mix Group at the moment and chairing today's session. Thank you all for being online. I'll just start with an acknowledgement of country. A lot of Mallee Integrated Cancer Services.
Yeah, well, look, you're doing great. So, yeah.
If you're online,
Quite good, Bob.
could you just put yourself on mute, Sue? I think I can hear you talking at the moment. Sorry. Thank you. Sorry. So we just like to acknowledge the Aboriginal and Torres Strait Islanders peoples as the traditional custodians of the land on which we live and work. And we acknowledge and pay respect to their elders, past and present. So again, thank you for all dialing in today. So just as a quick background, this cancer and sexual wellbeing community of practice is a really important topic in the overall holistic care for people with cancer. And we often don't get around to giving it time when we see patients in the clinic. At the LMIX annual forum last year, there was a lot of interest in this topic and a desire to form a community of practice in our region. And LMIX has got the fortune at the moment of having Krista Phillips, the social worker doing her Masters in Sexual and Reproductive Health, working with the team at the moment and helping establish this local community of practice. This session's going to be only 1 hour, and you could probably talk from each speaker could talk for several hours, I imagine, on their area. This is a bit of a taster session for potential topics, and we really would love to get your feedback on how the community of practice could support you in your work. And Krista will have some time at the end after the speakers to get some feedback and have a discussion about that. I'm going to introduce each speaker as we go through. They'll have a short presentation and there'll be opportunity to take questions after each session. And if you could raise your virtual hand and put that in the chat, we'll try and monitor that from our end. So Dr. Vijay Ramanathan is our first speaker, who's a senior lecturer in sexology at the University of Sydney. Dr. Vijay has 16 years of experience as an academic, practitioner and educator in the field of sexual medicine and sexology, and I'd like to hand over now. Thanks, Vijay.
Thank you, Rob, and thanks, Krista, for inviting me. And I would like to acknowledge the lands that I'm joining from. It's the Darug Nation in New South Wales, and I pay my respect to elders past, present, and anyone present in this meeting. Am I coming through audible?
Beautiful.
All right. First time in 16 years, I'm doing a presentation without a slide. So I decided to just talk today because the nature of what I'm going to say is very grounded, very human, very real. And I'm going, and before doing that, I really want to appreciate the organizers for calling it as cancer and sexual well-being, not just focused on health. I think well-being is a wonderful term because often in the discourse, we plug it in, health and well-being without really giving due attention to well-being. So that's really good that we are having a focused session on well-being. Now, the topic that I'm going to, or the perspective that I'm going to give is around silence. Now, silence, especially in that area of cancer and sexuality, is very important, and it's something needs to be addressed. Now, I'm going to share 2 stories, and I have permission from the 2 people involved to share the story. And let me start with the first story. And they both are related to me, so I can get a bit emotional about it because I witnessed it. So my mom, she's a cancer survivor, now 12 years now, 12, 13 years now, and she was diagnosed with breast cancer. And I went from here to India, and she decided not to undergo surgery without me being by her side. So I went there, the surgery happened. And then this is a setting in India, not a metropolitan city, but a second-tier city. She had the surgery, she was discharged. And then what happened, we were waiting for the surgeon to come and examine on post-discharge. And then she was waiting there with a towel on her shoulder And then the surgeon came in. It was a male surgeon, came in, no concern, nothing. He literally pulled off the towel to examine her. And as a son, witnessing, as a medical practitioner, witnessing that it didn't tick the box in so many ways ethically, but I'm not talking from the healthcare professional, what is the ethics, so that's not my point. I'm talking from the patient perspective, the discussion that I had with my mom, how she felt in that moment, that something she covered all her life, whatever the meaning you give to different body parts in that culture, the Indian culture, and in many cultures, it's related to something very private and something you don't show, and you kept it to yourself for many, many years. And still, the body, the breast tissues have been removed, but it hasn't been removed from her mind yet. She still thinks it's there. And somebody coming and ripping off the towel to examine her, she felt terrible. And because of my background in sexuality and counseling and other psychosexual therapies, that I was able to have a meaningful conversation. But I'm just thinking how many patients would be there not able to raise this. And that's something stood with me for a long time. So that's one story. And Krista, is this making sense? I just want to, is it coming across in the right pace?
Yes, I think it's good, Vijay. It's great. Thank you.
All righty. The second story is not as bad as this one. My sister was also diagnosed, and she underwent surgery, and she decided to remove her breast as well. And then what happened is, this was in a metropolitan city in India, and I was, was curious to get in touch with the surgeon who did the surgery and see what services are available. She was in her late 30s at the time. So I wanted to check what's available, or, what services she's offering. And then to my surprise, this was about 7 years ago. I was very surprised to see that the surgeon's website had a page dedicated for sexuality, which I thought, wow, this is fantastic. They are actually talking about these things. And then when I clicked on the tab, can anyone guess what I saw? Krista, you can't answer this question, but can anyone guess what I would have landed up seeing when I clicked on the tab sexuality? This is a surgeon, this is their hospital's website. Private hospital, by the way. Fertility, no. But good guess, Alyssa. What else do you think I would have seen, which really shocked me? Sorry, I'm getting a lot of background noise. Yep. Any guess anybody would like? This is a community of practice, so we can, there's nothing wrong. This is a safe space to share. Graphic picture or photo, no. Personal photo, no. I'll keep it for 30 more seconds, Rob. Sorry, I want to keep it on time, but abstinence, no. Great guesses. I'm loving this, but no. Oh, yep. Somebody said a blank page. Nothing. This really got my attention, because if there wasn't a tab called sexuality, it's bad, but at least it's not there. But somebody had the guts and thought about a page dedicated for sexuality, having it up there. And when a person clicks on the tab, it's coming up as a clean page, clean blank page. It's not a 404 error message or anything. It's there, the page, the site is active with a clean blank white page, which could be sending messages like unintended in a way, or there is nothing to talk about sexuality, or do not talk about sexuality. So that really got my attention. And then I approached the surgeon, look, and I introduced myself, my background. I spoke with the surgeon and I asked her out of curiosity, so what made you to have a tab but not put any information there? And she said, Vijay, I understand that this is an important topic, but I don't know what to write in there, because not many clinicians are trained in human sexuality. So they can feel it, but they don't know what to put it in there. So then, to cut the long story short, so I wrote a whole page of information with somebody who specializes in oncology and sexuality, my colleague, and then we wrote the page, and the information is still there for so many people to look and benefit from it. Now, I want to wrap up by saying one more thing. In my many years of working with general practitioners and primary healthcare professionals, one thing, why doctors don't initiate that conversation about sexuality. Do they not know about it? Are they not human about it? Absolutely wrong. They know, they understand the impact. They are human beings as well. They can totally relate to it. But there's nothing to do with cancer and sexuality. I'm talking from generally sexuality. One of the common reasons that I was told, and something I have witnessed, doctors, especially the primary care professionals, they don't initiate a conversation about sexuality is because they don't know what to do with the answers they get back from patients. So why on earth to open up a topic in which I'm not able to respond or be an expert or know a lot of information? And that's something I have worked on many years. And my key message when I train doctors in Australia and whenever I train doctors through conferences in India is you don't have to be an expert in order to help someone with their sexual concerns. You can be listening to it. Listening is half therapy. Well, listening, not just listening with empathy, listening in a non-judgmental way, and being willing to validate their concerns, and then admitting, look, this is something I can help you with, but then from here, where you can go for further help. And that's where professionals like Krista, who are becoming into psychosexual therapists, and there are many psychosexual therapists who are trained at Sydney University and Curtin University, and there's a whole professional body called Society for Australian Sexologists, where you can quickly search where, or you can give the link for the client to go search to find professionals who can help them with these sort of concerns. So my key message is, thank you for whoever decided to have such a meeting. And I wish I could stay for the entire 1 hour. So Rob, my apologies. Straight from this, I'm jumping to another training meeting for psychiatrists. So my apologies, but I wish all the very best and happy to be contacted for anything else. Any questions I'm happy to take.
Thanks so much, Vijay, for sharing such personal anecdotes. It's pretty humbling when you're on the other side of it as a family member, despite having a lot of experience in the field.
Yeah.
I think that really sets the scene pretty well for this group's founding. Are there any questions before we go on to the next speaker? I think a lot of it was food for thought, Vijay.
Excellent.
Awesome.
And I just want to leave by saying one thing. I think in the space of sexual, just coming into the actual topics, when we talk about sexual dysfunction, post-cancer, post-treatment, the other big elephant that often gets missed is the social adjustment. So when sexual dysfunction and social adjustment issues come together, I think that never gets very well addressed in the biomedical framework, but social adjustment is a key factor that gets tied up with sexual dysfunction. And between the two, the sexual function issues and social adjustment, hangs the health literacy and the cultural nuances. So if we can put all this in a mix, I think it becomes not just a multidisciplinary, but a well and truly an interdisciplinary care, and not just comprehensive, but it's a very well-phased comprehensive care, because which one needs to come first and later, that becomes a challenge. So that gets more into the academic clinical side, but I don't want to simply rush through for the sake of saying it, but I'll leave it there.
Thanks so much, Vijay. Thanks for your time and good luck with your next meeting.
See you. Bye-bye. See you, everybody.
Our next speaker is Associate Professor Safeera Hussainy. Safeera is the Senior Pharmacy Research Manager at Peter MacCallum Cancer Centre. She's also the Chief Investigator of the Alliance Trial that aims to expand pharmacists' scope of practice in sexual and reproductive health, and is the leading co-design of the Sexuality and Cancer Clinic at Peter Mac. Safeera also has an extensive media research and publication profile, and we had to cut the bio short because it'll take up all of their time. So thanks so much for joining us, Safeera.
Thank you so much, Rob, and such a pleasure to be here today. Am I coming across okay? Can everybody hear me okay? Great, thank you so much. I'm incredibly excited about this community of practice because this has finally come to fruition, and I know that a lot of people have been doing work in this field for a long time, including Vijay, the previous speaker, and I'm very new to this field, but to see this come to fruition today is such a big milestone. So congratulations to Lamix and Julie, Cheryl, Krista, Rob, and everyone else who's been involved. Let me see if this is going to work. Oh, sorry. Okay, so I'd like to just acknowledge country as well and the traditional owners of the lands on which the 6 cities of Peter MacCallum Cancer Centre, where I work at, are located throughout Victoria. I work at the Parkville campus, but today I'm joining from Werribee, where I live, and from the Kulin Nation and the Barnarong people of the Kulin Nation. I'd like to acknowledge the First Nations people are the traditional owners of the land and their connection to these lands, waters and skies that have been continuous for tens of thousands of years. And I recognise their strength and resilience and pay my respects to their elders past and present. So I was asked to talk about the rationale for the co-design of a sexuality clinic at Peter MacCallum Cancer Centre that I've been leading since I joined in 2021. So what I plan to step you through is the background and how this work came about, and talk a bit about the phase program of research I'm leading and what some of the findings have been in that research. So when I joined in 2021, I've been a sexual and reproductive health researcher for nearly 2 decades, specifically in contraception and related to the provision of contraception in pharmacy. So when I joined and when I looked at the literature and looked at what the possible sexual health concerns could be of people with cancer, contraception did come up as an important issue. And I came up with an EOI for a project and I submitted it to our consumer engagement team. They put it out to their consumer register, and I had a number of people who were interested and responded back saying, actually, it's not contraception that's important to us, it's sexuality. It's the libido, the body image concerns, self-esteem, self-expression, intimacy. These are the things that we're grappling with. So I said, right, okay, let me reorient my project, and if this is what's important to you, then I need to go with this, and I need to listen and come up with a program of research that could address or help address some of those concerns. So, sorry, whoops, I'm not having any luck here. Okay, so I've just put some illustrative quotes on the slide there to indicate some of the things that I heard and were shared with me. This zero libido plays out in my life every day. It is taxing. Quality of sex life equals quality of life. And I consulted 5 consumers, and I was so fortunate that 3 of those consumers, their photos are shown there with permission, agreed to be consumers on my program of research and have contributed so wonderfully to this program of research. I also spoke with some health professionals working at Peter Mac, and admittedly more of them were nurses than doctors. They were the ones who were interested to talk to me, and they said things like conversations regarding sex are taboo, but also sexual health is living too. So everyone is on the same page regarding this problem. We can hear that from the stories that Vijay shared as well. So the consumers thought that survival was prioritised by healthcare professionals over quality of life. And they reported not feeling heard, having to suffer from these sexual side effects in silence and with shame. Vijay spoke to us about silence, and that was affecting their intimacy, their self-esteem, and their partnered relationships. Health professionals, on the other hand, reported lack of time, belief that sexuality is outside of this practice scope, especially doctors who thought that this was within the scope of practice for a nurse, and stigma were limiting factors for health professionals. So none of this should be surprising to anybody if you look at literature around discussing these topics. When we look at the global context and situate our findings in the global context, we see that 40 to 100% of people affected by cancer experience some sort of sexuality-related concern. That's quite a high statistic. And if we then turn and look to best practice guidelines, they clearly state that sexuality care should be holistic and should be provided as part of cancer care from the point of diagnosis all the way through to survivorship. And as I developed this program of research, very recently I came across some work led by Dr. Andrew Matthew, who's a health psychologist at the Princess Margaret Cancer Centre in Toronto, where they have developed and implemented a sexual health clinic for patients with cancer. And this is for 7 host sites, which is very exciting. And we've recently developed a collaboration with them, and we'll be looking towards or to them for their implementation experience in shaping our work at Peter Mac. So the overall aim of the program of research I'm leading is to implement best practice recommendations by developing a sexuality and cancer clinic at Peter Mac. We do have 2 other specific clinics for pelvic dysfunction and for prostate cancer, but nothing for all cancers, and that is inclusive to all genders, for example. So in terms of the program of research, I've just highlighted that below. Phase 1, which I spoke to you about stakeholder engagement, where I spoke with consumers and health professionals. I then did a scoping review where we reviewed literature on what the policy and practice tools are to help health professionals to screen for sexual health concerns, and what are the guidelines out there. And we limited or focused, I suppose, on AYA, or adolescents and young adults, because we had to have some sort of focus, acknowledging that there are a number of tools which can be used across all populations. We also did an audit in phase 1 where we looked at trends regarding contraceptive counselling and sexual and reproductive health problem management in people with early breast cancer, followed by phase 2, which we are in at now, and we're currently analysing data from our co-design workshops. And in these, we wanted to really unpack what the unmet needs are of consumers and of health professionals, and what their priorities would be for a sexuality clinic in the future. And we also are going to be conducting an education needs workshop following a survey where we're looking at what sort of education our workforce needs to support them in opening up this conversation with patients. So the methodology underpinning this program of research is mixed methodology. It's quantitative and qualitative. So we've used things like surveys, workshops, storytelling, but at the heart of it is EBCD, which is experience-based co-design methodology, where we seek to actively find out what the needs are of everyone involved and everyone affected. EBCD has 5 steps, in which goes from setting up for success all the way through to monitoring and maintaining the experience. And storytelling is really at the heart of EBCD. Like Vijay shared those stories, they're so powerful. All the stories I've heard from the consumers and health professionals I've spoken with all point towards the same thing, but there's diversity in that too. So gathering those rich experiences, analysing them, and recognising that patients will often share more information in an interview that they may not otherwise share when they have permission to share. But as well, going to our staff and finding out what's most important to them and what they need to move forward in this area is really critical. So I'm just going to step you through the different stages or phases of the program of research very quickly. So the first one was the scoping review we did, and this has been published. And I'd like to acknowledge the student researchers on this for this work. It was Catherine Sun and Nu. I think Nu is online, Nu Taudin, and they led this scoping review. They analysed the articles, and what we found was that there are a number of policy and practice tools available. There's no need to create any more. However, they're not accessed as widely as we would like, and they do provide comprehensive range of information and advice in this area, but there's limited focus on AYA patients. Oh, sorry. The next phase was the audit that we did, a retrospective audit of EPIC, and we looked at contraceptive counselling and sexual health problem management. I'd like to acknowledge Yvette Maris, who led this piece of work, who was a student researcher at the time doing a biomedical degree. Yvette's got a nursing background as well. What we found very briefly is amongst the cohort of patients' records we examined, there were 94 records, only 11% had contraceptive counselling recorded. Now, the fact that we're looking at recorded documentation doesn't reflect necessarily that this didn't occur in practice. We have to go by what was recorded. So 11% had contraceptive counselling recorded where they were counselled and offered options for contraception, which we know need to be considered when you have hormonally mediated cancers. And only 8% of this cohort reported any sexual health problems. And again, it doesn't mean that they didn't exist or that they weren't experiencing them if they weren't asked the question. So this really points to a lack of recording and a problem with documentation in our health systems. We also looked at whether people were prescribed hormonal contraception and whether they continued to take it throughout treatment. And majority of our sample had ER positive, PR positive breast cancer. And we found that many of them, 10 out of 18, continued to take hormonal contraception. And the copper IUD, which is first line, and if you go to the FSRH guidelines, they recommend using this first line in people who have hormonally mediated cancers, but this wasn't recorded for anybody in our sample. So what we could conclude from that that contraceptive counselling and sexual health are poorly documented in breast cancer patients' overall treatment, and they're either under-prioritised or they're challenging to record in the EMR. So we have to, get our systems right when it comes to not just having these conversations, but recording them as well. Leading to the co-design workshop. So we're just in the process of analysing this data. We recruited 14 consumers and 9 healthcare professionals to work out what their needs are in this area. We conducted 3 workshops, 1 consumer only, 1 practitioner only, and 1 mixed workshop. It was very challenging, and there was a lot of gatekeeping around conducting these workshops from an ethics and governance point of view, but also from a recruitment point of view to hire a research assistant to be involved in this work. And I'd like to acknowledge Druvit, who's a research assistant on this work, and the pharmacy technician Sevda, who's helped out with transcribing the workshops. Recruitment of healthcare professionals was also challenging, and teeing up availabilities, as we know. We put out an advertisement to patients and amongst our networks, and also to healthcare professionals, indicating in there as well what sexuality means, that it's an all-encompassing definition. And we also developed trigger films to show workshop participants. Trigger films are a part of EBCD methodology, and they open up a conversation and get people talking and thinking about the topic. So how am I going for time? Sorry, can I just do a check-in?
I think we've got 2 minutes, Safeera.
Right, I might just skip through a little bit, and I want to actually show the trigger film, if it's okay. So these are some of the quotes, and one of the key quotes was, "You saved my life, but I have a life to live." And people called it a secondary cancer. They felt numb by the symptoms they were experiencing. They didn't know who to turn to or where to look for information. Healthcare professionals reported the same. They didn't know what resources to go to. They didn't even know what was safe to discuss. And just like Vijay said, they didn't have answers. They didn't feel adequately prepared. So what they indicated the need for were resources, education resources, and dissemination of our trigger films. So I'm just going to show you this, if it allows me to. This was the consumer trigger film.
Just can't hear it, Safeera.
Oh.
Yeah.
Okay. I'm not sure what's happened there. Sorry about that, guys. So you can't hear it all. You could see it. Okay. I might have to leave it because I don't know why it's not working, and I haven't got the tech expertise to figure it out. Sorry about that. But I do have QR. Sorry?
I'll try. If I've got it unmuted here, we'll give it another quick shot, Safeera, see if that works.
Okay. Do I need to?
Yeah, just press. Yeah.
Wait a sec. Apologies.
Okay. Yeah.
No, we
No.
can't hear. It'd be
No.
great to have if you've got a way to share it, that'd be great for us to have a look at afterwards.
Yeah. Yeah. I might just skip over this and sorry. If you want to look at our trigger films, the QR codes are there. But yeah, we've developed one for consumers and one for practitioners. And also just to acknowledge that none of this work would have been possible without, the 23 people that have been involved and the 87 individual voices who've contributed to, to move this work forward. So I'd like to just thank everybody who's been involved to date. And if you have any questions, please.
Thanks so much, Safeera. That's a lot to get through in a short period of time.
It was, I realise.
I think if we could leave those QR codes up in the questions, people could have a look, but also maybe we could send that out afterwards, if that's okay. Yeah. April, anything from a question?
Not on the chat at this point, no.
I've got a question.
Yep, we've got a question. Cheryl's got a question.
Hi, Safeera.
Okay. Hi, Cheryl.
I was interested that you did the literature review on AYA when obviously a lot of people that have cancer are in an older age cohort.
Yeah. To be honest, the AYA focus was driven by one of my collaborators who you might know, Associate Professor Jeremy Lewin, who works with AYA patients. So he had a particular interest in seeing if there were any screening or screening tools or guidelines available for AYA. Nevertheless, what we did find was that there are around 33 tools, screening tools and guidelines, but very few were focused specifically on AYA. So we kind of killed two birds with one stone. If you look at that paper, what we've done is a really nice summary of all the different screening tools and guidelines and the populations that they're targeted at and who they can be used for. So, the different genders, etc., or different cancers. So that's the reason why we focused on AYA.
Thank you.
Thanks, Cheryl.
I can't see any hands up on our screen here, but if you do have your hand up, just please say something. Nope. Alrighty, we might
just keep moving through. Thanks so much, Safeera.
Thank you. Thanks very much.
Really helpful. Our final speaker, last but not least, Cheryl Ludwick, who's working at Bendigo Health. Cheryl is a physiotherapist who's got over 30 years of experience in the area of pelvic health physiotherapy and postgraduate qualifications in this field. Cheryl's a senior clinician at Bendigo Health in the Continence and Pelvic Floor Clinic and also works in private practice where she works with patients before, during and after cancer treatment to try and minimise the effect of pelvic health concerns on their quality of life. Cheryl, thank you.
Thank you. I'm just trying to share the screen.
Yep, great.
Is that working?
Yeah.
Excellent. I'm going to talk today about a patient that I saw who had gone through breast cancer treatment and then she came to see me. So her name was Penny. She was a 53-year-old woman. She presented with painful sex, which is also called dyspareunia, and she'd been putting up with this for quite some time and had self-referred to see me as a result of speaking to a friend who'd seen me for another reason. Now, Penny's history was that she had experienced breast cancer 6 years prior. It was estrogen positive. She'd had a mastectomy and follow-up treatment, which included radiation, and she'd had Zoladex initially, and then she'd been given Arimidex, which is an aromatase inhibitor, just to inhibit the hormones. She'd had some complications after the mastectomy, and because of the fear of complications, she'd actually declined a reconstruction. So Penny had recently shifted to Bendigo after a divorce. She attributed her marriage breakdown to the lack of intimacy that arose after her breast cancer treatment, and that she thought that was the main reason. Since being in Bendigo, she'd met a new fellow who she found to be really sensitive, understanding, and was actually considering exploring physical intimacy again, which is why she'd come to see me. So overall, she was pretty healthy, was still on Arimidex. She did have some anxiety, and her GP had suggested medication, which she declined. And some of the things that she was saying was that her self-image was significantly affected by the cancer treatment and surgery. And you can see the comments that she was making there. She didn't feel desirable anymore. She was really concerned about her partner seeing her body. She hated the scars. So there was a lot going on for Penny. The summary of the assessment really started at looking at what physical symptoms she was having. So she was having severe pain with any penetration attempts, and it had been quite a while since she'd tried. It had got to the point where it was impossible, which is a condition called vaginismus, where the muscles actually spasm and prevent penetration. She'd also developed some difficulty emptying her bladder and her bowel. And on a physical examination, she was tense everywhere. So her abdominal muscles, her diaphragm wasn't moving properly. She had some vaginal atrophy, which is a situation that develops after menopause, and she'd been thrown into an early menopause with the hormone suppression. She had high tone, very tender pelvic floor muscles and poor relaxation of the pelvic floor. So what I wanted to look at was some of the contributing factors for Penny that were contributing to her presenting problem, which was the painful sex. And just going through a few of these and then the treatment options that I looked at from a physiotherapy perspective. So we know that menopause can contribute to vaginal changes. So she'd had a fairly significant instant menopause that had been triggered initially by the Zoladex, and then she was on ongoing hormone suppressant. As a result of the vaginal atrophy, the vagina becomes dry, and then sex can become painful. And when you have pain with sex, the next time you have sex, you kind of expect it to be painful, and things tense up, and it becomes a self-perpetuating problem. And there's some anxiety that can develop around that as well. And it can get to the point where it's almost a subconscious response of the body where the muscles tense up, even with the thought of any kind of penetration, and then penetration becomes very difficult or impossible. Now, some of that high tone in the pelvic floor may have developed because of the fear of pain. Some of the high tone may have been because of anxiety, generalized anxiety. There's a lot of interplay between these features, so it's hard to really pin down what causes what. It's about managing what presents, really. A high tone pelvic floor can create bladder and bowel dysfunction, which it had in Penny's situation as well. She couldn't relax to empty her bladder or her bowel. The whole situation was quite stressful, and stress levels can also contribute to the high tone, and the difficulty that she was having with her relationship was also contributing to that. And on the other side of this little diagram is an area which, as a physio dealing in the area of pelvic health, I'm talking about a lot of the time, but I don't consider my skills to be excellent in this area, and I do try and refer on, but we talk about these things. So she talked about the fact that her libido and her arousal had dropped as a result of the hormones, but also relationship difficulties contribute to that, stress levels contribute to that. She was feeling miserable about herself. She didn't like her body. She didn't feel desirable. So all of that was as a result of the changes to her body from the cancer treatment and the mastectomy. So what can we do about these things? So from a physio point of view, I'm looking at the physical things as well as looking at the overall well-being. But some of the practical things that we started with, looking at the vaginal changes, looking at some non-hormone options initially for Penny. And there's a variety of those around. And some women can also look at vaginal estrogen if it's appropriate, just to help to improve the health of the vagina. So some of the non-hormone options would be vaginal moisturizers like Replens or Dr. Wolf's products that are easily accessible from pharmacies. There's a variety of different personal lubrications that can be used for penetration. And where it's appropriate, topical vaginal estrogen can be used after breast cancer treatment. There's always studies coming out to show safety or not of these treatments. The study that I've referenced there by Best and colleagues was a meta-analysis and systematic review that was just published early this year. And they looked at the recurrence rate of breast cancer after the use of vaginal estrogen and found it to be generally safe unless people are on aromatase inhibitors, where there's a slight increased risk of recurrence. However, some of the big studies say that there's not an increased risk of mortality, but there is an increased risk of recurrence. So it's worth looking at some of those if you're having discussions with your patients. So that helped to manage the, so looking at that, we were managing the dryness, and then we looked at managing some of the high tone situations that were going on. So overall, Penny needed some general relaxation, which assists with anxiety management, but it also helps with down training the tension in her core muscles, in her pelvic floor muscles. We focused on some pelvic floor muscle down training as well, some specific exercises for that, and helped her to regain control over that natural response of tensing up. In addition to the relaxation, to prepare for penetrative sex, it's important that people improve their confidence and reduce the fear of penetration. And one of the ways that pelvic physios assist with that is the use of vaginal trainers. Now, vaginal trainers are also known as dilators. I really don't like the term dilators because it assumes that you're trying to stretch something. And in some cases where they're used for maintaining sort of the opening of the vagina after radiation to that area, yes, that's appropriate. But in this case, it's more about training the vagina and training the muscles to be able to relax to allow penetration. So it's about building confidence, adapting to the sensation of something going in and reducing the fear associated with the penetration. Patients can maintain the control of this and progress it as they're able to. And this is just an example of one of the types of dilator sets that I would recommend to patients. So that certainly helps them to get used to it. By the time they get to the largest size, that's usually similar to the size of a penis, and then they can progress from there. But it's a big jump from going to using vaginal trainers to using a penis in real life. So there needs to be some education and progression through there. Looking at the area of intimacy and body esteem and sexual self-esteem, this is an area where I have a few skills, but I prefer people to see a sex therapist if they're able to, because they have far more skills than I do. I can give some basic advice, but I really can't provide the psychosexual counselling that some people need. Fortunately, Penny was amenable to seeing a sex therapist, which she accessed online. There are lots of online options that people can access if they would like to. And with the sex therapy that Penny was able to offer, was able to access, the sex therapist talked about lingerie and draping to help her feel more comfortable about the changes in her body. She had some specific counselling about, how she was thinking about sexuality, and she was started on some sensate focus exercises, which is another area. I'll often give people advice about these exercises as well, but that's where the focus is not so much about penetration or sex as such. It's more around focusing on pleasure and the sensation of touch and experiencing pleasure from just being in contact. So the outcome of Penny's intervention with me, we got some great improvements. So general pelvic floor relaxation, she did really well with that. There was actually a little bit of improvement in her anxiety with the mindfulness relaxation strategies that she undertook. Her vaginal health had improved with the vaginal moisturiser, and she'd started to engage in some non-penetrative sexual contact, but she was still quite self-conscious, finding it helpful to use the lingerie. She did really well with the trainers. So she attempted some penetrative sex with an appropriate lube, but there was some splitting of the skin of the vulva due to the atrophic changes, and that was causing some issues and some pain. So Penny had a discussion with her oncologist, and they decided to try a low-dose vaginal estrogen after discussing the risks. And because she'd been on the Arimidex for 5 or 6 years already, there was some discussion about potentially stopping that because everything seemed to be really well controlled. So after that approach, Penny returned to pain-free sex. It took us 8 months. But she got there, and she was really happy that she'd actually taken the step to make contact with me. So what could have been done better? That's what I always ask myself. I think that Penny felt that she didn't have sufficient information about what might happen and how her sexual well-being would be affected by the treatments that she had. And I know there's information out there, and there's lots of information that you can access online, but sometimes the information is presented at a time where people are dealing with being given a cancer diagnosis, and they don't necessarily take it in. So I think it's a good idea to touch base with people periodically when they're seen during their cancer treatment pathway, and just check in and ask the questions, because sometimes they're too afraid to bring it up themselves. But if you ask and check in, it gives them the opportunity and opens that door for them to start to discuss any concerns that they may have. With hindsight, I probably would have introduced the sex therapy option a little bit earlier in the treatment pathway. And that's something that I'm doing more often now. And also encouraging her to access some specific counselling around the anxiety, because the anxiety tends to feed some of the issues that she was having with her sexual well-being. And that's just a reference for the article that I spoke about earlier. And any questions?
I've got a question.
Yeah. Hi, Linda.
Hi. So I was a bit late today. I had a client till 1:30, but I'm here. Thank you very much, Cheryl. That was really interesting, and it's really important work. And as a psychosexual therapist, I'm thrilled that you're including what we do. Is it within the way you're trained, or the way that a pelvic floor physio might practice, to actually invite the partner in to actually talk together about what's going on with her body and how that, and find out. And so obviously, the whole lot of therapy stuff in there about how they might communicate, which is probably not part of your role. But would it be appropriate to have him obviously with shared consent, to be part of that process, to talk about what does sex mean for him and what kind of penetration and those kind of physical practicalities?
Yes, that's something that I do with some patients, depending on where they are in their relationship and whether their partner would like to be involved. Yes, it's patient dependent, but I'm very open to that, and I'll often encourage them to bring their partners with them.
Can I ask another question?
Yes, of course.
The trainers, vaginal trainers, do you talk about inducing or talk about arousal in that context? I mean, is it just a kind of clinical, I need to get something in, or is it like talk to them about the potential of sensual self-touch, maybe finding some kind of material that they find erotically engaging and use that in the context to give it sort of motivation? Or is that, again, I can't see your face because all I've got is on my screen, I'm just seeing the question slide. So yeah, I always wonder why not, if it's all about arousal and pleasure, why not introduce arousal and pleasure in that context?
That is introduced. I'm just trying to stop sharing my screen. Am I back?
No, you have. You're all good.
Yeah. Yes, I do talk about arousal, and in the room where I practice with one of my colleagues at the private practice, we've got a couple of little vibrators in there that we've got to demonstrate to people, and we talk about the benefit of arousal and self-touch in the whole process. Yes.
Right. I think that's really cool to hear. Thank you.
Thanks.
Yeah, thank you, Linda. Some good questions. Thank you, Cheryl.
Yeah, you take the floor now, Krista, if you'd like to.
Okay, are there any other questions? There hasn't been anything online. Oh, thank you so much, Cheryl. That was very interesting. I'll just share out the next step for people to have a chance to. Sorry.
While you're logging on,
sorry.
I'll ask Cheryl one more question. How good do you think our general ability is to talk about sexual health outside cancer diagnosis? And do you get a sense, do you have a gut feel of how many people that you're seeing by the time they've got to you have what their sort of base health, their base literacies around sexual health? Like, do you feel that you are seeing a representative demographic, or do you think you're likely to see people that are more motivated and feel comfortable talking about this? I don't know if I phrased that question well, but do you know what I'm trying to get to?
Yeah, I understand what you mean. I don't think I'm seeing anywhere near the number of people that are having problems. The ones that see me, some self-refer. I am getting referrals coming through from the cancer centre, but often it's later in their pathway. I think it would be excellent if they could be referred early in the pathway. But you're right, the ones that do come in are the ones that are very comfortable talking about it. So I wonder whether they've actually raised the topic themselves and asked for some help. Is that answering your question?
Yeah, thank you.
Thank you, and thanks for tolerating my slide. I think everything had gone so smoothly until that point. That was my major anxiety about the whole thing. But yeah, so thank you, and that was a great question. And it does make me think, Cheryl, and this, if the people that are that, if they are at the point where they are confident to talk about it to a health professional, it means they've had a bit of practice before somehow often, and where they start to get that practice and that permission to talk to people about it. And so everyone's got a role to sort of open that up at some point, I think. So that makes a good point. So I'd really just love to thank Vijay and Safeera and Cheryl for offering their time today and their wisdom. It's been fantastic, and also for Limicstop being the foundation for starting this process. Thank you, Cheryl. Someone's asked, do you take referrals from other health services to Cheryl? I think it is.
Yes,
And what sort of wait time? And yeah.
The wait time is the problem. Yes, we take referrals from anyone.
Yeah.
It depends on where people are referred. So the wait time currently in the Bendigo Continence Pelvic Floor Service is around 5 months. At the private practice that I work in, and there's 2 pelvic health physios that work there and do similar work, it's probably around 4 months currently, which is unfortunate. We get cancellations there and people can be brought forward earlier, but that's kind of roughly what we're looking at. Yeah. In relation to do we take referrals from anywhere to Bendigo Health, we are kind of restricted to our zone. So outside of Loddon Mallee, no, but this is a Loddon Mallee event, so hopefully people would be within this zone. Yeah.
And I guess part of the community of practice is to start building those networks up and down the Loddon Mallee and beyond for the people here, so we can certainly expand on our knowledge in those areas every time we meet, and just in communication in between. So something I've got up there is the survey link, so it should work if you click your phone on it, and that's to about a 3-minute survey monkey. Some people I know have already done it, thank you, who are up on the screens. But that's just to give us some feedback, not necessarily straight on today, but please do that in the other comments or any comment part. And also it's about your input into what the community of practice can focus on going forward, when you'd like to be, how often you'd like it to be. I have realised I've probably put some limitations in the questions to try and keep it short, so please don't feel upset if there's something I've missed or an area I've missed, and please put it in the other. And if you're not either a nurse, oncologist, GP, or view yourself as an allied health, please just put down allied health and put in what you are afterwards. I realise I probably limited a bit in that area, but I consider anyone working alongside this field as an ally in to the health process. And it'd be great to get your feedback, and moving forward we're hoping to continue this onward, and this was a bit of a snapshot of what it might look like. We'd love to have a case presentation, we'd love to have someone specialist in a certain area talk. We could have like a bit of a general chat about how things are going, and even work on some advocacy across the region for access and support of people living with cancer, and also certainly include some consumers and people who've had that experience, of which I'm sure there are many amongst you today anyway. So are there any other questions or comments at this point in time? I think we've done pretty well with our time. We've almost got a few minutes to go. No? Would you like to say? Oh, yeah. So, yeah, thanks, Cheryl. So, part of the questionnaire is also that you can comment if you'd like to be involved as a bit of a small team to work on the community of practice as well. So please put your details down if you'd like to do that, or do a presentation, or any ideas. And the other thing I'll also be doing in the background is keeping via the Limits page, there'll be setting up a section related to the community of practice, and we'll also be adding some resources behind that as well, so people can click into that, and they'll be relevant for the Loddon Mallee area and also beyond. So ones that from someone that's been recently trained in academia in this area, I hope it to be the most up to date and seems relevant, but always happy for people to add to that.
Krista, can I just make a comment? Thanks.
Yeah,
I'm
hi, Julie.
Julie from Limix, one of the project managers. So at the annual forum last year that we held on this subject, we put together a list of resources from each of the presenters, contributed their knowledge and experience around various resources and clinics and what have you. It would be really great if we could maybe use this community of practice to continually update that as a resource and make sure that we reshare it. Maybe that's what you're talking about on the web.
Yeah,
Great.
Certainly add to that and have have access to it via the internet.
Some of the people here today have probably never seen that list, so that would be really good, I think, to resend. Thanks.
Excellent. So I guess thank you so much everyone for coming. The enthusiasm has been great. It's so good that everyone's so interested in this important, but as we know, often overlooked topic. So let's hope we can expand and keep learning. That's the main thing, isn't it? Keep curious. All right. Thank you.
Congratulations. That's great.
Thank you very much.
Yeah. See you. Bye. Thanks.
Sorry.